Hello everybody, my name is Paul Poommipanit. I am a hybrid CTO operator at University Hospitals Cleveland, here to talk to you about antegrade wire escalation. These are my disclosures. Before we talk about antegrade wire escalation, I think it's important to go over some definitions. A chronic total occlusion is defined as a total obstruction of the coronary artery that is greater than 3 months old. This excludes acute and subacute occlusions. So for example, if you have a patient that's been having chest pain for 2 days, presents with a non-STEMI with a troponin of 20, and on angiography has a total occlusion of a coronary artery with collateralization, this is not considered a chronic total occlusion, even though you may use some of the same techniques that you use in CTO PCI to revascularize that particular vessel. Antegrade wire escalation is the use of increasing stiffness of wires to cross a chronic total occlusion. And so I'm going to start at the hybrid algorithm. This is a figure taken out of Dr. Berlakis' book. This is an algorithm developed a number of years ago that gave us predictors of success or failure in CTO PCI using various techniques. So for example, if you have a patient with an ambiguous proximal cap, poor distal target, and a lesion length greater than 20 millimeters, the likelihood that you're going to be able to wire this with antegrade wire escalation is on the lower side, and the likelihood that you're going to need an advanced technique such as antegrade dissection reentry or retrograde is much higher. That's not to say that if you run into a patient with a 30 millimeter lesion, most of us will try antegrade wire escalation in hopes that we cross into true lumen distally and increase the efficiency of our case. If we use antegrade wire escalation as developed in the hybrid algorithm, it really consisted of 3 wires. There was a soft taper tip polymer jacketed wire, followed quickly by an intermediate weight polymer jacketed wire, followed by a stiff hydrophilic non-jacketed penetration wire. And so it really looked like this Google map of Cleveland where there were 1 or maybe 2 options for antegrade wire escalation. And since that time, technology has essentially exploded this particular area to the point where it looks like this map of Northeast Ohio. These are all the university hospital sites in Northeast Ohio. And so you have the Fielder series wires, you have the Sentai and Gaia wires, you have the Miracle series wires, you have the Confianza series wires, you have the Pilot and Persuader series wires, you have the Progress and Provia series wires, you have the Judo series wires, and you have the Whisper series of wires, and many more. And so when I think of these wires, I try to categorize them into 4 different groups. So the first group is the taper tip soft polymer jacketed wire. These are typically 1 gram tip load or less. They're tapered tip, they're polymer jacketed, the prototypical wire being the Fielder XT. Since that time, there have been many other wires that have come out. This is by no means a totally inclusive list, and if I left a wire off, it's my apology. The next group of wires in my mind are the intermediate polymer jacketed wires, with the prototypical wire being the Pilot 200. There have been advances in this space as well, with technology improving steerability, as well as other factors such as penetration power, and in the case of the Gladius Mongo wire, the ability to prolapse the wire into the subintimal space. This third category of wires I call the steerable wires. These are typically tapered tip hydrophilic wires of increasing stiffness with additional technology to improve steerability and torqueability. These are typically wires that are used to cross into the true lumen. I don't think there's much room in the hybrid algorithm for most of these wires, although I've seen a lot of operators use these wires with a reasonable amount of success. I will say in my own practice, I will rarely pull out one of these wires when I know exactly where I'm going and I need a lot of tip control. This fourth category of wires is what I consider the penetration wires. These are typically tapered tip, hydrophilic, non-jacketed wires. Tip loads range anywhere between 10 and 20 grams. These are typically used to cross proximal and distal caps. I will advise that if you're going to use this wire to cross a proximal cap, to make sure to de-escalate after you cross the cap. So in typical fashion, you penetrate the proximal cap with this wire, you move your gear past the proximal cap, and then you de-escalate to an intermediate weight polymer jacketed wire to traverse the rest of the lesion. If you push on these wires hard enough, they will go somewhere. And so if we go back to the hybrid algorithm, we started off with a soft taper tip polymer jacketed wire, then quickly moved to an intermediate weight polymer jacketed wire, followed by a stiff hydrophilic non-jacketed penetration wire. In the past few years, I've seen many different iterations of antegrade wire escalation. The prototypical hybrid algorithm progression is Fielder XT, Pilot 200, and Pro 12. Since that time, I've seen XTR, Mongo Pro 12. I've seen XTR, XTA, intermediate weight jacketed wire followed by a penetration wire. I've seen XTA, a Gaia progression, and a penetration wire. I've seen an intermediate weight jacketed wire followed by a penetration wire. I've seen a Miracle series progression. I've seen a Judo series progression, and I've seen a Gaia series progression, as well as many others. And so in my own personal practice, I'll use a soft taper tip polymer jacketed wire if I believe there's an antegrade microchannel. If I don't see an antegrade microchannel or I don't believe there's one there, I will skip this wire since it is the highest failure rate wire in the CTO registries. I'll go to an intermediate polymer jacketed wire, and the wire I'm currently using is the Gladius Mongo wire. If this is unsuccessful, I'll move to a stiff penetration wire if I know where the vessel's going. If I'm in the subintimal space, I'll pretty quickly move to a antegrade dissection reentry or retrograde strategy. My success rate with antegrade wire escalation over the past 2 years is about 60%. I realize that I could probably increase this if I used some of the steerable wires. However, if I'm in the subintimal space and I have another way of getting it done more efficiently or just as efficiently, I'll go ahead and do that as opposed to taking another wire and trying to get back into the true lumen. So in conclusion, there have been advances in wire technology that has aided in the expansion of the coronary CTO space. I think much of what we're going to do in the antegrade wire space is going to be dependent on the skill level of the operator. If you're comfortable with retrograde and comfortable with antegrade dissection reentry, you're probably going to move to it pretty quickly. Whereas if you're not entirely comfortable with these techniques, you're going to spend more time doing antegrade wire escalation, and you're going to use more steerable wires to try to get through the distal cap and into the true lumen. This is my contact information. If you have any questions, please email me, call me, text me. Thank you for your attention.